Welcome, everyone, to the People's Health Briefing, a key component of our Trusted Voices campaign. I'm Dr. Noha Abalada from Ridge Community Health, reporting for the week of November 17th, 2025. As health professionals rooted in Oakland, we know that we are a community that's often at the forefront of public health challenges. We know that the issues we discuss, from chronic disease to community violence, impact neighborhoods and cities all across the country and the nation. We are speaking to all of you today, of course, wherever you are, but this week is especially heavy here as the community is bearing a tremendous shared grief. And I'm talking about the tragic and senseless loss of Coach Bean, a mentor, a colleague, and a pillar of this community. He was the kind of leader who gave generously and made a lasting positive difference in the lives of thousands of our young people and their families and beyond. His death, coupled with the violence that touched one of our schools just the day before, has shaken us all. I want to be clear, gun violence, the things that lead to it, the trauma that it creates, is a public health crisis. This is not just an enforcement issue. This is not just a school issue. It is a systemic health issue that requires a systemic health response and action. We know that this trauma doesn't just disappear. It lives in our bodies, it impacts our mental well-being, and it threatens our children's futures. The public health solution to this crisis requires all of us to step up. Every single person, whether you're an educator, a parent, a sibling, a coach, a frontline health worker, a neighbor, we all have a role to play in building a protective shield around our youth. Coach Beam was a one-of-a-kind example of what true positive mentorship looks like. His passing forces us to look hard at the adults who are shaping this generation. We know that positive mentorship is one of the most powerful protective factors against violence and despair for everyone, but especially our young people. So I wanted to touch briefly on 3 actions we can take for community healing. First, be trauma-informed. If you work with children, we urge you to assume that every young person you encounter is carrying stress or trauma in some form or another. Lead with patience, curiosity, and compassion. Your patience, your listening ear is a public health and a mental health intervention. Number 2, step up as a mentor. If you don't currently work with youth, consider becoming a mentor. Become the positive adult the next generation needs. If you have the capacity, consider volunteering or stepping up in some way for a young person. Your presence is protection. And third, hold the line on standards. We have to demand more from the institutions and adults who carry responsibility towards our youth. We must actively reject any harmful practices and recognize red flags in those that are working with our children, like public humiliation and shaming, emotional manipulation, like making a young person think that their value is just conditioned on their performance, and ignoring a child's life outside of the classroom or the field, demanding performance despite not knowing maybe what is going on for that young person in their home or in their life. And we know that there is tough love and different styles of coaching, but we want to make sure that we name it when we see any of these red flags, because these behaviors can directly contribute to the toxic stress that we are trying to mitigate. So if you see something, say something. Positive youth development is not optional, is absolutely fundamental to public health and to our future. So we must remain vigilant and protective against social vulnerabilities, and we have to apply that same vigilance against all threats, including biological threats. And to do that, we have to have the capacity for surveillance and data monitoring. But unfortunately, as we know, over the last few weeks, the public health community has been grappling with severe blind spots created by the temporary stoppage of federal data reporting during the government shutdown. We've had data blackouts. We have not had our weekly reports on all of the things regarding public health that we've come to rely on from the CDC. And all of this disruption and continuing to have to rely on imperfect and patchy data sources underscores the fragility of our surveillance system. But what we can report today is that some of the data pipelines are flowing again. So let's start with the epidemic trends for COVID and flu, which have been updated through November 8th. Some sources are still lagging. As a reminder, when we talk about epidemic trends, we are referencing models and forecasts based primarily on data from emergency department visits. This gives us the clearest real-time picture of community spread. So taking a look at COVID epidemic trends, we can see that the growth is mainly on the East Coast and Midwest, as shown on this map in purple and pink. On the West Coast, COVID infections are decreasing or likely decreasing, which is depicted there in the shades of green. And in many states shown in gray, things are not changing, at least not yet. So while the COVID-19 picture shows stabilized or even decreasing trends here on the West Coast, the story is entirely different when we look at influenza. Taking a look at the flu epidemic trends map updated through November 8th, you can see that activity is accelerating rapidly. Influenza is currently growing or likely growing in the vast majority of states across the country. This signals that we are firmly in the period of seasonal growth. And while flu activity overall is relatively low now, the trend is rapidly moving into moderate and high ranges. And this is especially concerning when we consider what we know about the circulating strains. The last flu season, 24-25, was a high severity season, and the dominant strain then was H1N1. Now, as the current season begins to accelerate, we're seeing the dominant strain so far as H3N2. And seasons dominated by H3N2 typically correlate with even greater severity and higher hospitalizations than H1N1 dominated seasons, especially among older adults. So it is imperative that we treat this early acceleration of flu cases with urgency, which includes vaccination for everyone 6 months and up. This acceleration is a critical public health warning. Remember, exponential growth. We have to be proactive. We're not waiting for the whole map to turn red, even though they don't make it red anymore. Now they make it dark purple, but we're not going to wait for the map to turn where we're having very high cases everywhere. We are going to act on the direction of the data. So if you have not received your annual flu vaccine, the time is now. And when we take a look at respiratory viruses percent positive, so these are tests being done in the United States, the biggest driver of respiratory illness right now is still the common cold. So that gray line there shows us that about a quarter of all positive respiratory tests in the US are currently for rhinovirus enterovirus, leading cause of the common cold. So while most of these infections are mild, enterovirus infections can in rare cases lead to more serious issues. But for the most part, we are seeing a fair bit of respiratory illness that is milder. It's not COVID, it's not flu. So this doesn't mean we should lower our guard against the more severe threats that lead to hospitalization and death that we can prevent. Flu, COVID, RSV, especially since we know that those are on the rise. And now we're going to shift our focus to the growing measles crisis across North America, including the major development that Canada has officially lost its measles-free status after 3 decades. Canada had maintained elimination status since 1998, meaning that there was no endemic spread or local spread of the virus for over 12 months. But a resurgence that began in October 2024 continued spreading for more than a year across several provinces, pushing Canada past the World Health Organization's threshold. Over the last year alone, the country has reported more than 5,000 measles cases. The hardest hit provinces include Ontario with about 2,400 cases and Alberta with nearly 2,000 cases. Since Alberta has a much smaller population than Ontario, it has the highest concentration of cases in the country. Alberta is a Western province where political emphasis on personal freedoms has contributed to higher rates of vaccine refusal. But vaccine rates across the whole country have slipped in recent years. Only 79% of 7-year-olds were fully vaccinated as of 2021, which is the most recent year that data was available. So only 79%, and that is down from 83% in 2019. Experts cite several factors to explain this decrease in vaccination, including limited access to primary care, the absence of a national immunization registry, and importantly, growing misinformation. Public health officials across the country have been working hard to counter this rise in measles. Since March, Alberta alone has administered over 130,000 measles vaccines, which is a 50% increase from the same period last year. So that is a bit of positive news, but much more will be needed to restore population-wide immunity, since, as we know, 95% of the population must be vaccinated to achieve herd immunity for measles. So still a ways to go. And to regain elimination status, Canada will now need to demonstrate 12 consecutive months with no endemic spread, a process that officials warn could take several years. So the country is now working with the Pan American Health Organization, or PAHO, to develop and implement an action plan to increase vaccination coverage, strengthen surveillance systems, and improve rapid outbreak response. Because Canada lost its status, the entire Americas region, which first became measles-free in 2016 and then again in 2024, is now considered to have lost elimination status once again. This region has faced setbacks in recent years, particularly due to outbreaks in Venezuela and Brazil, although both countries regained elimination status last year following large-scale coordinated vaccination campaigns that were very successful. So we can't look at the rise of measles in isolation. Measles is one of the most contagious diseases in the world, and public health experts warn that its resurgence may signal the return of other preventable diseases, including those that are less contagious, like polio. The rise in measles cases in Canada is occurring alongside surges across the region, particularly in the United States and in Mexico. If the endemic spread continues, the United States will reach the 1-year threshold in January, and Mexico will reach it in February, putting both countries' elimination status at risk. Across the entire Americas region this year, PAHO reports 12,593 confirmed measles cases, 30 times the number reported last year. So absolutely heading in the wrong direction fast. The United States is experiencing its largest measles surge in more than 3 decades, with over 1,600 cases reported to date this year. 2 major outbreaks continue to grow. The first outbreak is in South Carolina, which we've discussed in previous briefings. That will be linked in the video's description. As of November 14th, South Carolina Department of Health reported 8 additional cases, bringing the total number of cases since July 9th to 47, with 44 of those associated with a single outbreak in the upstate region. The second major outbreak is located along the Utah-Arizona border and is now the second largest measles outbreak this year, following the outbreak in West Texas. This border outbreak has reached 184 cases. The Arizona Department of Health has reported 128 cases, including 17 new cases this week. And in Utah, the Utah Department of Health and Human Services reports 77 measles cases, including 60 in Southwest Utah and 10 newly added next week. Low vaccination rates in these communities have created ideal conditions for rapid spread of measles. So overall, the measles situation across North America is a stark reminder that elimination does not mean eradication. Elimination is temporary. Declining vaccination coverage can swiftly undo decades of progress. And this is why we are absolutely concerned about other viruses that are vaccine preventable when we start to see a decline in vaccine coverage, and that includes polio. So we've covered a lot of important critical ground today, touching on challenges that demand our immediate action. So to close, I want to leave you with 3 non-negotiable public health commitments for the weeks ahead. And these fall under the umbrella of vigilance and protection, which are critical components of public health. First, protect our youth. Let's be trauma informed. Be that trauma informed protective adult you had or wished you'd had. Reject harmful practices in every area. If your family or any young person you know is struggling with grief, anxiety, or fear, contact Roots for care or visit our website for additional resources. Next, protect against seasonal threats. Act on the direction of the accelerating data, not the current low numbers. We're not going to wait. We are going to get our flu shot, our updated COVID vaccine today, everyone 6 months and up. Let us not wait for it to be full-blown season and it be too late to get yourself that valuable protection and prevent the spread to those that you love and those around you. And third, protect our public health foundation. Let's prevent the return of old threats that we thought we had eliminated. Check your family's immunization records right away. We have to ensure high measles, mumps, rubella vaccination rates, also polio vaccination rates in our community, among others too. So we want to avoid the crisis that is being faced not only by Canada, but also here in the United States regarding measles. The work of community health requires constant vigilance, but it is achievable when we act together. So thank you for doing your part to protect the well-being of our communities. This concludes today's People's Health Briefing. Thank you so much for joining us, and we'll see you again next Tuesday at 10 a.m.